Good afternoon. I'm Cynthia Minkovitz, Chair of the Department of Population, Family, and Reproductive Health, and it's my extreme honor to welcome you all to the 12th Annual Paul Harper Lecture. A special warm welcome is extended to Allie, Sandy, Nini, and Jeannie, and is Justin here? I think he's, oh, there you are. Welcome. It's really a privilege to hold this celebration annually in Paul's memory and honor, and to celebrate his many contributions. As you know from reading the program, Paul was a visionary public health leader and teacher. He founded our department in 1947, and while it evolved considerably in those early decades, Dr. Harper remained at the helm until 1970. During his tenure, the department incorporated both international and domestic public health issues with expertise spanning from child health to family planning and population science. Those foundational interests continue to be well represented in the department today, and I know Paul would be particularly intrigued to meet our speaker, whose work addresses both international and domestic public health concerns focused on children, focuses on prevention, and is grounded in both life course and the health of populations. Delighted to introduce my colleague and this year's Harper lecturer, Dr. Maureen Black. She is the John A. Scholl and Mary Louise Scholl Endowed Professor in the Departments of Pediatrics and Epidemiology and Public Health at the University of Maryland School of Medicine. She holds additional appointments here in international health and in psychology at the University of Maryland, Baltimore County. She's founded a growth and nutrition clinic, a multidisciplinary service addressing the needs of children with poor growth and feeding challenges. She's trained as a psychologist with a master's from the University of Southern California and a Ph.D. from Emory, and her research focuses on modifiable factors in children's environment that can promote their health and development. The scope of her work is impressive and expansive. In addition to her clinic work and her work locally and internationally, she is a sought-after mentor for postdoctoral trainees as well as junior faculty in nutrition and psychology, some who I'm delighted have migrated to this side of town. And she's held leadership positions in many professional organizations, as well as serving on multiple committees for UNICEF, WHO, and the World Bank. Please join me in extending a warm welcome to Dr. Black.
Thank you, Cynthia, and thank you very much to the Harper family, and thank you to you all for coming. It's clearly an enormous honor to be invited and welcomed by your hometown colleagues. I'm absolutely thrilled to make the short journey across town and to be here today. So thank you very much. I never had the pleasure of meeting Dr. Harper, but he certainly, whether he knew it or not, has influenced my work and the work probably of most people in this room, starting as a pediatrician and then developing expertise and interests in population dynamics and in maternal and child health. He clearly was a visionary and has had a major impact on where we are today in terms of our health. His book, Preventive Pediatrics, Child Health and Development, is one that could be timely today as it was when he wrote it. I'm going to start by talking about some history. In 2003, there was a series of papers in the LANCET which looked at where and why are 10 million children dying every year. This was part of the child survival movement. And there were multiple interventions that took place throughout the world. And lo and behold, 10 years later, there was another series in the Lancet that showed that the number of children dying had declined from 10.8 million to 7.6 million, or roughly a 30% decrease. So this was an enormous effort and gave evidence that we as a world certainly could make monumental changes. This was part of the time of the Millennium Development Goals, which was a very successful anti-poverty agenda from the 1990 to 2015. So the Millennium Goals had many successes, yet there was clearly unfinished business. But poverty was cut in half, primary education enrollment increased to 90%, gender equality and primary education increased, fewer children died, maternal mortality was reduced, Children received and adults received services for HIV and reduction in malaria deaths, and clean water, and debt service decline. So these are wonderful advances. But where's early child development? Missing, not part of the Millennium Development Goals. So there's unfinished business and unfinished agendas, unfinished topics to think about. People who do the same kinds of things tend to work together. So I and some of my colleagues wondered what happened to those children who survived. It's wonderful that there are fewer deaths, more children surviving, but what has happened to them? So there were two series in the Lancet, one in 2007 and one in 2011, that looked at early child development. And what the 2007 series found was that there are over 200 million children under age 5 in low and middle income countries who were not reaching their developmental potential. Now, there were no measures of child development at that time, so we used proxy measures of stunting and poverty. And the series in 2011 looked at the inequalities of early childhood and what some of the risk and protective factors were. Some of the major risks included nutritional factors as well as infections such as malaria and violence and maternal depressive symptoms. So there was much work that was to be done. Now, in the intervening years from that 2000 to 2015, there's a tremendous amount of momentum in early child development. The scientific publications increased sevenfold. There's more funding, not enough, but more. And the number of people who were interested in early child development increased. There were economists, and there were folks who had really never been interested in child development before, started to get the bug. Approximately a third of countries adopted policies around children and early child development, and much more support for early child development. So that's all good news. In 2011, and then published in 2014, there is a third series on early child development. So I'll talk some about that series. All of the papers are available on open access at the URL that you see at the bottom. This series included 3 papers and 8 commentaries and notes. So the commentaries endorsed early child development, and they were written by the people that are listed. So Margaret Chen, the Director General of WHO, and Tony Lake, head of UNICEF, the head of the World Bank Group, and Ban Ki-moon from United Nations. So this illustrates that child development has moved to the attention of international leaders. So what's new in this series? Why did we need another series on early child development? There are 2 primary categories on what's new, the science and the policies. So we'll talk a bit about each of these. So the science is that there's a focus on the youngest children. This is from conception to age 3. There's a life course approach, and there's an intervention which we'll call nurturing care. So I'll tell you more about these. In terms of the policies, we have an updated estimate of the burden of children not reaching their developmental potential. There's a cost of inaction, and then widespread endorsement of the early child development as a strategy to achieve the Sustainable Development Goals. So this is some of the science that has been brought to us by neuroscientists. So the brain architecture starts very, very early during conception, following conception. There's a plasticity at this period where there's an interaction between genetic influences and the environment. The environment is basically divided into 2 areas. There's what's called experience expectant and experience dependent. So experience expectant is information that is species-specific and expected for brain development. An example that's often given is the formation of the neural tube closure that happens about 22 days. It starts about 22 days after conception, often when women don't know that they're pregnant. And it's influenced or dependent on nutrition, on folic acid and on B12. So it's an illustration of how nutrition influences development at a very, very early stage. Experience dependent is information that's unique to the individual. That's why some speak English, some speak Bala-Marese, some speak French. It's what you've heard. So it is unique to individuals. So understanding these experiences has been part of what has influenced very early child development. Now, what this illustrates in terms of early brain development is that for each one of these, so neuron proliferation or axon and dendrite growth or synapse formation, myelination, and apoptosis or programmed cell death, you can see that they start prenatally. And some extend shortly after, so some extend 4 or 5 months postpartum, and some extend up through adolescence. The point is they're time limited. They start early and they're time limited. This slide illustrates it just in a slightly different format. This slide illustrates early brain development with age on the x-axis. So it starts at conception, goes up by months, and then at 1, it goes up by years. I drew a box around the first 1,000 days, which includes the 9 months of prenatal from conception to birth, and then 24 months up to age 2. So if you multiply that out, that's 1,000 days. And if you look at what's happening in terms of brain development during that period, you can see it's an incredibly active time with development of the visual and auditory cortex, with myelination starting, and it's a very, very active time. And when I show this slide, I always ask people to put themselves on the slide. Can you find your age? Are you on there? Okay, and what's happening in your brain right now? Not much. Just trying to hold it together. So if you were interested in investing in brain development, when would you invest? Would you invest in yourself? I don't think so. So it illustrates that the time to think about early brain development is early because these things stop. So it starts during the prenatal period, but it also stops fairly early in development. So it's a very unique time. It's a time of both vulnerability and opportunity. And this is some of the basis of the 3rd LANCET series on investing in children very, very early in life. So what this shows is that if we think about parents' health and well-being, and this is from a pre-conception, and there are students in your department who are working in this area because I heard them this morning. And if we think about the environment preconception and during pregnancy and then during early infancy, what we have are opportunities to influence the genetic blueprint that wind up influencing health, learning, and behavior throughout life. So the life course perspective of this is a strong part of our development. This slide illustrates some of the interactions that take place across the lifespan. So you can see it begins, there's a cycle beginning in fetal development, and then infant and child growth and development, adolescent development, adult health, and then there's an intergenerational aspect, so that it continues The cycle continues throughout the life course. So we see that the foundations for healthy and productive life are set in early childhood. Again, more reasons to invest early on. This is some of the evidence that drives these conclusions. These are two papers that were published in Science in 2014 that have the similarity of following an early intervention into adulthood. So the one on the left is called the Abecedarian Project. It was done in North Carolina, where 100 young at-risk children were recruited at birth and then either got a very high-quality child care where they got nutrition and health care for 5 years, or they didn't. And they were followed then throughout life, and those children who had the intervention did better in school, had better psychological development, and when they were followed at age 35 years, this is what they found. Blood pressure, metabolic syndrome. So why is that? Why do we have these health effects on these kids after 35 years? Well, what happens is very early in life, they started to separate in terms of obesity. So that by the time the children were 5, those children who were in the control group and not getting the intervention were heavier than the children who were. And the habits that the kids developed in child care stayed with them and manifested themselves in terms of blood pressure, metabolic syndrome. So this is an illustration of how what happens very early in life then has an influence throughout life. I will tell you, as I told some of the students earlier, I have a recent grant funded by the National Institute of Diabetes, Digestive, and Kidney Disorders, NIDDK. Who gets diabetes, digestive, and kidney disorders? 50-year-olds, 60-year-olds. Do I study 50-year-olds and 60-year-olds? No. I study 3-year-olds. So this is a child care grant to help kids and families develop healthier habits while they're young, with the idea that these healthier habits in terms of lifestyle, of diet and physical activity will extend throughout life, so that when they're 35 or 45 or 55, they're less likely to have metabolic syndrome or diabetes, digestive, and kidney disorders. The study on the right was conducted in Jamaica. In this study, children who were stunted either received a home visiting with a nutrition component or they didn't. And when they were followed as they grew up, those children who received the intervention did better in school, had better psychological development, and at age 25 they earned more money. Well, Paul Gertler's an economist. So the economists are very interested in what happens to children and what the long-term outcome is of these early interventions. So this is some of the evidence. This is some of the evidence that has driven our thoughts about very early development. And what this illustrates is the epigenetics that happens in early development. So it's a gene and environment interaction, then plays out throughout life and plays out in a whole variety of areas. So it's adult health and well-being, and things like cardiovascular disease, obesity and diabetics, diabetes, mental health, cognitive function, and behavioral and social function. This illustrates the life course perspective of child development that starts at conception and then moves through up to adulthood and then into the next generation. So as one is on a trajectory, the trajectory is stronger, and that's the predictability of early development. But what can happen if things go awry, then it starts early and it might not look so large early. But what happens is the disparity becomes greater over time. And this picture portrays a child who's stunted. So, and there clearly is evidence from the studies in Jamaica as well as studies in Guatemala into the next generation that where there are, the price continues to be paid by children in the next generation. So a life course perspective guides early child development. What this slide portrays is a positive aspect in that if we look at the green line represents an optimal developmental trajectory, the red represents a disparity, and what the blue represents is an intervention. And that when the intervention starts early, and this could start earlier, is that it pushes the red up to the green. If I were clever with PowerPoint, we'd have it moving, but this is as far as it goes. So, but you get the idea in terms of an intervention. So it shows us that if you start early, there certainly is lots of room for improvement and things we can work on. In the LANCET series, we assemble the information that is known about early intervention, and we talk about what's called nurturing care. So nurturing care is what kids need, and this is something that your grandmother could tell you that kids need. It's not rocket science. Kids need healthy nutrition. Of course they need healthy nutrition. And they need health care. They need protection. They need from immunizations. They need strong health care. And they need responsive caregiving. Responsive caregiving means someone who listens to them, not just someone who talks to them, but someone who listens to them, who notices what they're doing and reflects back to them. And they need protection from danger. That means protection from violence within their home, outside their home, protection from toxins, protection from all kinds of things. And they need opportunities to explore, learn, and discover. Well, that's what kids need, but there are many, many children in this world who don't get that. So this is what it would look like if they did get it. First, they'd be getting it from their parents and caregivers, and it would look like talking to their child and playing with your child. It would look like breastfeeding your child. It would look like complementary feeding your child. It would look like, again, playing with your child, and it would have moms and dads. So this is what it would look like. Doesn't seem so difficult, not very snazzy, but this is what kids need. So how do parents provide that? They provide it, and how do we parents provide it? By making sure that parents have the capacity to be providing nurturing care. And how does that happen? Well, can you provide nurturing care if you don't have a home? Not easy. Can you provide nurturing care if you are depressed? Not easy. So what that means is that providing support for families to be able to provide nurturing care then protects children. So early child development programs then assist families and assist children. So you'll recognize this. This is an ecological model. And what helps child development programs? That means having national policies. That means having investment in child development programs that then influence families and enable them to provide nurturing care to parents and children. I think this is the kind of thing that Dr. Harper talked about. Am I right? That he talked about making sure that what parents cared about is early development and making sure that the children were healthy and safe and developing well. So this is a model that we think about. Now, what if we don't do this? What if we just stay where we are and we don't invest and life goes on? Well, we calculated that there are 249 million children who are not reaching their developmental potential. And this is where the economists come in. Psychologists don't do this. So if we look at those kids who are stunted only, or poor only, or stunted and poor, and we look at their grade deficit. So what grades do they not succeed at? And then we look at the income lost, and we multiply it by the number of children, we will get a number. And that will tell us what's the cost of doing nothing. Well, the cost of doing nothing, looking at grades and income lost, is 26% of an average adult income, or it's 26% of what could be a GDP. And you can look at the cost in various countries. Well, what country could afford this? Very difficult. So the argument is to think about investing early in life so that we don't have what's lost. Now, what's happened is that the Millennium Development Goals have ended, and now we have the Sustainable Development Goals. And these at least have a bit of a mention of early child development. Not enough, but there's one that says that all girls and boys have access to quality early childhood development education that's prior to primary school. So that's at least a start in the right direction. And what has happened is that the leaders of the World Bank and the World Health Organization and UNICEF look to early child development as being a way to be successful in the Sustainable Development Goals. Because after all, for this to work, we have to have children who become adults who have the intelligence and the creativity and the health and the dedication to make decent decisions about where countries are going and what countries are investing in. So it's a tie into the SDGs. So in order to prepare for the SDGs, there are several things that are needed. I told you that we estimated the children not reaching their development by using proxy measures. Well, proxy measures of stunting and poverty served for a while, but what we would like is direct measures of early child development that are based on a combination of caregiver report and direct observation and testing, so that we could determine who's on track or off track. And we need to think about how to scale up. So I'll tell you about some activities that are moving forward, hopefully in a positive direction. And that is that I'm involved in a group that is attempting to follow the guidelines of the WHO growth standards for height and weight that have been adopted by over 140 countries to develop standards for early child development using some of the same kinds of principles. So what that would mean is that we would recruit healthy children from low, middle, and high income countries representing multiple regions, and have psychometrically strong instruments along with standard operating procedures and quality assurance to develop standards. And that those standards could be used at a population base to determine populations that are on or off track. And that subsequently these could be used for implementation and dissemination and capacity building, enabling countries to monitor their own progress, and ultimately having a global monitoring report on early development. So these are in process. We're at the point of having a concept note and looking for those who might like to invest. The scaling up is looking for developing effective interventions to support nurturing care. So this means policies to support families and integrating with existing services such as healthcare. So it's expanding what may be done in traditional healthcare to include the feeding and responsive caregiving and child protection and opportunities to explore and learn. Again, isn't this what Dr. Harper talked about? Seems like the similar message, very similar message. So these are some of the, these are the authors who were involved in the LANCET series. You can see there are quite a number of them, and these are some of the disciplines that were involved, supported by the Gates Foundation and the Hilton Foundation. So you can see that child development has become very integrated with expertise in many different areas. So now I'm going to talk about domestic issues, and I'm going to talk primarily about Children's HealthWatch, which is a collaborative project that I've been involved with. This started in the late 90s after the Personal Responsibility and Work Opportunity Reconciliation Act, which is welfare reform. And the welfare reform was deemed to, the primary metric was getting people off welfare. Okay, so what our concern was is, well, what about the kids? What happens to kids if parents get off welfare? So the Children's HealthWatch group we formed, and we looked at how policies and economic conditions relate to the health of low-income children and families. That means kids who are on Medicaid or have no insurance. So we developed this project that has ongoing cross-sectional surveys that are administered to caregivers of young children, birth through 3, in emergency departments and primary care in 5 urban medical centers, so Baltimore being one of them. So all centers had growth and nutrition clinics to care for children who were underweight. So you didn't just count them, but you could take care of them. So I've directed a growth and nutrition center for more years than I should probably admit, certainly from the end of the 90s. So this project has been ongoing through the generative contributions of several foundations. This is the website for Children's HealthWatch. So I will tell you some of the things that we have done with it. We have data on over 60,000 children, ages birth through 3, and we study food insecurity. This is food insecurity is studied by an 18-item USDA developed household food security scale. So what we have learned is that children who are raised in households where they're food insecure have an increased risk of poor health, of poor development, and of having been hospitalized. But it's not related in this 0 to 3 age to their weight, not related to being underweight or overweight. But their moms have an increased risk of depressive symptoms and of being in fair or poor health. If you're housing insecure, that means you don't have a stable place to live, you're at increased risk of fair or poor health and development, poor development, and poor weight for age. So what we learn is that housing and health and food insecurity are really health risks. They're not just uncomfortable for a city, they're health risks. And we also learn that food insecurity is invisible. You're not going to see it. And we call it hidden hunger. And if you don't ask, you won't know. So you have to ask to identify people who might be food insecure. So what are the mechanisms? How does food insecurity work? Well, we know it's episodic. So this is in the US. I'm not talking about a low-income country. I'm talking about the US. It's episodic. It comes and goes. When you have a check or the beginning of the month, not so bad. End of the month, very bad. So this is related to anxiety. Anxiety. Now, if you're food insecure, the first thing that you do is cut the quality of the food. So this is a nice steak and eggs. Forget it. You're not having that. This is what you're having. Ramen noodles. The nutritional value of ramen noodles is low, very low. So if you are cutting, after you've cut the quality, then you cut the quantity. That means you're not even having the ramen noodles. So the mechanisms that are driving food insecurity are stress and nutrition. Sometimes we think it's nutrition only. It's not. It's also stress. So if we look, these are just some data of Children's HealthWatch to show you the kinds of data we get. These are based on children from data from 2009 to 2015, and 23,000 children. So when we look at our kids, what we see is that the risk of obesity is higher among the older children than it is among the younger children. And this is a national trend. You can find this anywhere. And that the rate of underweight is lower in older kids than it is in younger kids. So the question was, how is this related to food insecurity? Well, when we look at food insecurity, that what we see is that it's not related to children's obesity or children being underweight, that the adjusted odds of obesity by age are the same. So again, food insecurity is invisible. You cannot see it. These are data from Baltimore. So from now on, I'll show you Baltimore data, not data from the other sites. So what this shows us is the prevalence of food insecurity from 2006 to 2015. You'll notice that it goes up. And why is it going up? Why did it go up? What happened in 2008? We had a recession. So what we see is that it started to go up in 2008, but for many of us, what happened a little bit later? We recovered. Well, low-income families don't recover. That the rates of food insecurity went up and they stayed up. So certainly is a concern, and that means things like environmental influences like a recession has a very big impact on those who can least afford to deal with it. So low-income families. So we developed a policy brief for Baltimore. We did that with the collaboration of the City Health Department, and we did that when Josh Sharfstein was the commissioner. So what Dr. Sharfstein said to us, you determine food insecurity with an 18-item USDA scale. That scale, it cannot be administered in clinics or elsewhere. Why don't you develop a screen? Oh, that was an idea. So we did it. We were smart enough to listen to him. And we realized that the mechanisms of food insecurity, as I showed you, included stress or anxiety and included access. So we took the first two questions of the USDA food security scale, and we looked at how those measured against the 18-item scale. This is a paper that we published in Pediatrics in 2010. We found a sensitivity of 97% and a specificity of 83%. Not bad, pretty good. So we also looked then at what the validity of the screen was. So we used, this is the screen, and this is the household food security scale. So you can see the odds ratios are perhaps slightly attenuated, but they're all significant. So what we find is that this screen works. So what happened in 2015 is the American Academy of Pediatrics issued a policy statement saying that all pediatricians should screen for food insecurity using the 2-item, which we sometimes call the hunger vital sign, using this 2-item screen. And that if you find it, then what you should do is refer children to food programs, nutritional assistance programs, such as WIC or SNAP, or in Maryland, we also have Maryland Hunger Solutions that can help clinicians find solutions. So that was a positive thing, and thank you, Dr. Sharfstein, for the suggestion, and that's what has now happened, is that there are additional validations of the 2-item screen for adolescents and for adults. So this can be done in many places. So now I'm going to talk about, this is fitting on our 2nd anniversary of the Freddie Gray incident in Baltimore. And as you will remember, most of you probably lived here then, On April 12th, Freddie Gray was arrested and he sustained injuries in a police vehicle, and 2 years ago today, he died, followed by riots and protests that were claiming racism and social injustice. These are the neighborhoods. I told families this morning I'd be showing zip codes. So the stars represent the zip codes where the unrest occurred. The green dot right here represents the University of Maryland. So remember, we had data that we've been collecting through Children's HealthWatch. So this is when the civil unrest occurred. So we had data prior to the unrest, during the acute period, and then following the unrest. We also added a survey here to ask about the impact of the unrest on the daily operations or daily behavior of families. So did it impact their sleeping, their eating, or their moving around their community? These are the analyses that we did. These analyses were done by Doris Yimgang, who's a graduate student in Epi at Maryland, and sitting right there. Raise your hand. Here we are. Yay, Doris. So, we did a Cochrane-Armitage trend analysis to look at the prevalence of maternal and child health problems by residential proximity. That means those zip codes where the unrest occurred versus the other zip codes in the city where it didn't occur, but were all within the city. These are all families, again, who are Medicaid-supported families. And then a piecewise logistic regression to look at changes in maternal-child health problems prior, during, and following the unrest. Then a Sobel test to look at whether those maternal concerns about daily activities mediate the relation between proximity and maternal-child health problems using SAS and M+. These are the sample characteristics. And you can see that there are not many differences based on the zip code. The proximal zip code is where the riots occurred. The distal are the other ones in the city where it did not occur. It's primarily in African American communities. 3/4 or so have finished high school. And you'll note that almost half the children are under 12 months of age. So these are babies. The mean age of the moms is 26. These are young moms and young babies. Well, let's see what happens. Okay, the way that we read this is the proximal neighborhoods are red, the distal neighborhoods are blue. And this is the prior to the unrest, this is the acute period of the unrest, and this is the following period. So it's a significant difference. Those who live in the proximal area are more likely to report maternal depressive symptoms than those in the distal area. About 5 months following the unrest, it returns to essentially what it was prior to the unrest. This did not occur for the other child health problems that we looked at. So that would be looking at child health, or looking at maternal health, or looking at developmental problems. But it did appear for maternal depressive symptoms. So this is the mediation analysis. Residential proximity is related to their concerns. Concerns around daily and community activities are related to depressive symptoms. When you put the model together, these are marginally significant. So what we see is that prior to unrest, the rates of depressive symptoms were about 20%, that the proximity to the unrest increased the likelihood of depressive symptoms during the acute period, reaching up to 50%. 5 months after the civil unrest, the maternal depressive symptoms returned down to the prior rates. and that maternal concerns regarding daily and community activities was a partial explanation for the relation between the residential proximity and the maternal depressive symptoms. So what are the implications? Well, this civil unrest often reflects the social injustice and a lack of equity. And depressive symptoms can undermine maternal well-being and negatively impact parenting, especially among young children who are very dependent on their parent and their parents' moods. So it suggests we should reduce social injustice by providing basic services for communities and families, like housing and food, and that we need policies that protect moms. Best not to have unrest, but to protect moms from the chronic community violence that we're experiencing, and to be aware of the vulnerability of maternal mental health. This paper is in press in the American Journal of Public Health. So in a summary, there's really an ecological perspective to equity. This represents the nurturing care that we talked about from a global perspective, but it applies whether it's global or Baltimore is part of global. So working with children and families is great, but it's not enough. You need to work with the community and involve the policies as well in order to have the reach that reaches, in this case, throughout Baltimore and has the sustainability. So I'm very fortunate in that I work with some wonderful, wonderful colleagues, great students, and have had the fortune to have some investments by some generous donors, and I thank you very much. And I think we have a few minutes if people have questions or comments. Yes?
Okay, so thank you. My question was about your comment about what's going on in our brains right now, kind of a lot, and yet the observation that we really need to work with families and communities and policymakers and others, so who also have experienced a lot of things in their own childhoods that might make them not very able to be the nurturing caregivers and to build that caring capacity both in families as well as reflected in policy. So I'm hopeful that there are strategies actually to help us evolve, and I think that some of the sciences are pointing to that. So what does that mean for the kinds of things and interventions that we focus on with families that help them heal so they can develop their own nurturing capacities? If they don't have it, that may be partly because of their own childhood. So.
What you say is very true. First, my comment that there's nothing going on in your brain is technically not true. It's in a hyperbole, and it always gets people's attention. So there are things going on. On the other hand, we're also at a point where things are being lost. But your larger point, which is that what about people who have not had that nurturing care themselves, and do they have the capacity to learn that? And it's a very good question, and it certainly is a concern. And what we've learned, and often through the School of Hard Knocks or through difficulty, is the strategies that we need to help families embrace some of those, the nurturing care, goes beyond talking. It goes into things like coaching. We have, I run this clinic on Fridays. Every Friday morning I learn a lot. And one of the things we do in this clinic is we videotape every family having a meal. And then we use that videotape both diagnostically and we use it therapeutically. So therapeutically means is that we enable families to model from themselves, and that you can always find something positive, so that you can always say to a family, to a mom or to a dad, you can say, look at him, look at you. Look how important you are to him. He is just tracking you all over every time you move. He's looking at you. It is very powerful. We actually wrote a paper about this. So you need strategies that enable families to make a move. And the little pamphlets and the yap, yap, yap just doesn't do it. So as we've become more technologically savvy, and we are technologically savvy in Baltimore, just as we are in India, perhaps more in India, in terms of things like phone or that using videos and using coaching to be able to help families. Every family wants the best for their children. We have a project in India, and we had the families, we do qualitative work before we do things, and we ask the families what they want for their children. This is in a place where 40% of the preschoolers are stunted, and the rates of anemia are 63%. They wanted their kids to be smart, clever, so we named our project Grow Smart. So they all want the best for their kids, but you need these kind of innovative strategies, not run-of-the-mill, sit behind your desk, think of something. No, you need innovative strategies.
Thank you.
Thank you. Yes, Dr. Blum.
Thank you for a wonderful, wonderful talk. I think that you may be aware that all of the students here who take child health and development read 2 out of the 3 LANCET papers that were released. The question I have is less about the data, and it's more about LANCET commissions. This was the 3rd round of the LANCET commission. What, from your perspective, is the leverage of this type of commission? Your data was very interesting and very compelling domestically. How you took an 18-measure question or set of questions down to 2, and it has become the recommendation of the AAP across the United States. How have you seen this work leveraged globally? How have ministries picked it up? Ministries of finance picked it up, etc.
Thank you. Wonderful question. You know, it's often not easy to measure the impact of your work. We measure it by how many people have cited your paper. That difficult. So from a global perspective, I can give a bit of evidence. So Grand Challenges Canada has a program called Saving Brains. If you read the preamble of Saving Brains, it says, because there are more than 200 million children who are not reaching their developmental potential, ... That 200 million children has been cited and cited and cited. So that got people moving. We can't afford 200 million kids. That's over 1/3 of children under age 5 in low and middle income countries. So that got people moving. I led of the 3rd series, a Lancet series, I led paper 1. And we counted painstakingly, 2 students, both who are med students now, counted the number of papers that included child development. And as I showed, there's a 7-fold increase. So that was positive. Now you mentioned the finance ministers. We had the launch of this Lancet series hosted by the World Bank Group. So the launch was on one day, and the next day there was a meeting of ministers where Jim Kim encouraged the ministers to think about nutrition and early child development. What ministers were they? Health? No. Education? No. Finance? Finance. So they were the finance ministers. So when I made several comments about the economists being involved, you need people from many stripes involved. You need the health people involved, you need the nutrition people involved, you need the economists, and certainly you need the child development people who are involved. So we're still, the jury is still out on how much of an impact there will be. Talk is cheap. So now the strategy is to try and find more examples of strong investments and strong impact. Any more questions? Thank you very much.
Thank you.